Again, the and lovely talk by Vikas as usual. Covered almost of the findings and challenges after cataract surgery when you have corneal edema and you're considering endothelial keratoplasty. So what I will focus on is I will focus on pseudophakic bullous keratopathy that tends to occur a little later. And this is the typical scenario because most patients who present to you with corneal edema, especially if you're in a referral practice, have gone through the gamut of all kinds of treatment that the referring doctor has already tried before they finally refer the patient to you. So you will see significant on several different kinds of presentations, but there are a few important things that you should note and you should look out for in a patient who comes to you with PBK. For example, this is a patient who presented again several months after the initial cataract surgery. What you will notice in the in several patients of PBK, you will see a lot of them will have stromal folds. You will see that several of them have Descemet's folds, and you will have epithelial edema as well, like in this case. OCT again is really useful in cases of PBK. And the early changes that you will notice is a thickened Descemet's membrane, and you will also start to see irregularity of the corneal epithelium as well as the formation of some microbullae where you will see clear spaces within the epithelial sheet. Patients like this usually do very well when there is no significant amount of stromal scarring, and postoperatively, they usually tend to resolve very quickly. And this is post-op day one. And sometimes, even though you might miss this in the initial period, this is post-op 4 months of the same patient, there might be some amount of surface scarring because of inflammation on the surface that tends to cause the scarring. And this really does not go away, but it probably also does not affect visual acuity to a significant extent once the epithelium has relayered adequately as well. And that's post-op 4 months. You'll see that the cornea is almost back to its normal thickness after this TBEC surgery. More severe cases that tend to present after cataract surgery, and in this case, you also will see that there seems to be some damage to the iris, and there probably was a traumatic surgery, though the IOL is present in the bag. What you will see in these cases are more significant bullae, and you will have to deal with a larger pupil. And you can see similar findings with intraepithelial edema as well on the OCT. And again, these kind of cases, this is a post-DSEC. You do expect that you will have some residual scarring, especially in the area of the bullae. And these are cases that visual acuity might not improve to the complete extent of 20 by 20. You also have patients who present to you with a significant amount of subepithelial fibrosis along with bullae. And these are patients typically who are several years out after the cataract surgery. They've waited or they've been made to wait before they've had an intervention, which is a bit unfortunate. But if you look at the OCT of these patients, in the periphery, you will see that there seems to be a pre-existing pathology for such severe bullae in one area. And this patient actually, it's not seen very well here, but the patient did have a localized central Descemet's detachment. And what you will also see is a significant amount of subepithelial fibrosis, but most of the stroma is clear. And the OCT is again very crucial to make a decision whether you should do a full thickness penetrating keratoplasty or you should do only an endothelial keratoplasty. Because if you have a very good cleavage plane, the majority of these patients do really well by taking off this subepithelial fibrosis and the epithelium. And this is the same patient 3 months post-operatively, and you'll see that the cornea is cleared really nicely. And the cornea actually, this is post-DSEC, has deswelled quite nicely as well. So you don't need to worry about subepithelial fibrosis as long as you get an OCT and you know that there is not enough significant scarring in the anterior stroma, and you will get a good result. In fact, in patients who have such significant scarring, as you can see with subepithelial fibrosis, you actually, during surgery, you can even do this at the slit lamp, and you can check and see if the underlying corneal stroma is clear. And the majority of cases, you'll be surprised to see how clear the underlying stroma is. And once you do an endothelial keratoplasty, you will have a very good result. The only issue is in some cases who might have been referred to you is if patients with long-standing PBK, if somebody is attempted to do an ASP multiple times, like you see in this patient, the post-op result with the kind of scarring that occurs in the corneal stroma because of ASP, which is actually something that is induced, is going to again preclude full visual recovery, and you need to be careful about being able to identify this too before you do surgery. The other interesting thing in cases of PBK, especially in eyes that have some sort of inflammation, is you will notice that the wound sites in these eyes tend to become very prominent. And you also see some fibrosis of the Descemet's membrane over the wound sites. And this is important again from the point of view of surgical planning, because you would want to avoid these wound sites when you're doing endothelial keratoplasty. And even post-op, you will see that, pre-op, you see that there is reduplication of Descemet's membrane, small area of detachment overlying the wound site in these cases. This is the same patient post-op 1 year. Patient is doing really well, but we avoided the wound sites to make sure that we created a new incision. And in fact, you will see that there is a bit of past that is formed between the iris and the new incision that has been created to do the surgery. And though this is DMAC surgery, you'll see that overlying the incision site, there is still a detachment. And this is something that you need to expect and avoid, because when you have a wound that is that has excessive fibrosis or scarring, especially of the posterior stroma, you can get quite a bit of irregularity, and your Descemet's membrane might not stick as well as you would expect to the posterior stroma. You might also have surprises like this. This is a patient who underwent a filtering surgery. Apparently, the filtering surgery, like an iridoenthesis that went wrong several years ago, and he had an ACIOL, and this patient was operated more than 30 years ago, and eventually he developed bullous keratopathy, was a one-eyed patient. So we decided that because he had this IOL in the eye for such a long time, that we were not going to touch the IOL, and instead we just did a DMAC, and that is enough in a patient who's had a lens in the eye for such a long period, where obviously the amount of corneal edema that he would have because of a stable lens probably is going to change over a very long period of time. So I would leave a lens in place like that. In other cases where you have more recent surgeries, like in this case with an ACIOL in the eye, where you have a lot of pigmentation on the Descemet's membrane as well, would be a good idea to exchange the lens and replace it with a new lens, either iris fixated lens or a little sutured lens. And these patients, again, they tend to do really well after you've done their surgeries for them. This is again a DMAC in that patient. There are some subset of patients after PBK who seem to have a localized area of inflammation in the eye after surgery. And again, you will see that they will have more superficial vascularization than other patients. So you're doing the OCT, you can see that there is epithelial reduplication in several areas as well. But post-operatively, this patient did really well. And you will see that the cornea cleared very nicely, including the posterior stroma. But if you look at the posterior stroma a little more carefully in the area where that patient had that source of inflammation, you will typically see there is some scarring of the posterior stroma or the pre-Descemet's layers. Since this is not in the visual axis, this is not going to be significant clinically, but this is something that you can expect to see in patients who have that localized kind of scarring. You also might see patients with PBK who have significant pigment dispersion, and those who have pigment dispersion, you should expect to see a lot of retrocorneal membranes in these patients as well. And you should be aware of this when you're doing your surgery, because it's not just the membrane that you take off, but also the Descemet's membrane in these cases. Same patient preoperatively, you can see the posterior stromal folds, and the patient post-operatively about 1 year or so later, again seeing that the cornea has cleared really nicely after surgery. So this is another patient who had TAS and inflammatory TAS, and clues to the diagnosis of a TAS will again be a very prominent internal lip of the incision, as you can see right here, a dilated and a fixed pupil, potentially because there is of inflammation or a severe rise of intraocular pressure after the TAS has occurred. You also need to be careful that in patients who have had inflammation in the eye or any traumatic cataract surgery, always look for CME, because this is something that you would want to pick up at the time of surgery so that you can actually treat it at the same time as well. So this is, again, the same patient who had a DMAC after the initial TAS surgery. You need to be a little careful about the size of the pupil and the graft touching the IOL. And you can put a suture to reduce the size of the pupil if you think that will help you with handling of the graft intraoperatively. The other interesting aspect of patients who've had TAS is you also will tend to see some amount of higher reflectivity in the posterior stroma, the pre-desmase layer, especially in patients who tend to have a significant amount of posterior stromal folds and DM thickening. So expect this, but this again does not compromise visual acuity to a large extent, and the recovery is usually quite good as well. Other patients of TAS will also tend to have these fixed folds in the posterior stroma on the desmase membrane. These are again something that will be transient. This is the patient with a fixed dilated pupil post TAS, and this is the same patient 1 year after surgery. So this patient did really well, and you will see that the fixed fold also has gone away without any issues in the eye. Very rarely, and there is only one patient that I've seen pseudophakic bullous keratopathy with such a thick retrocorneal membrane. You can see this is a patient who had significant amount of inflammation post-operatively. It formed a thick fibrous membrane, and in several areas, this is actually attached to the iris. So once you take this off, you can see the rest of the anterior chamber pretty well. But also remember that there's a desmase membrane behind this. Once you take off this retrocorneal membrane, that you will need to take care of as well. Sometimes you also will see patients who have had a ACIOL that has been implanted more several years ago and doesn't seem to impact vision very much. But those patients who've had a recent surgery and have an ACIOL in the eye, it probably is a good idea to exchange the lens and replace it with a lens that is either behind the iris or in the sulcus, or a lens that is sutured to the sclera. As you can see here, this is a lens fixated with the Yamane technique, and this patient is doing really well about a year after surgery. Some of the longer term changes that you can see in PBK, like in this case, post PK, then post failed graft, you see that this patient has spheroidal degeneration here as well. This again does not probably impact your surgical procedure, but it can lead to symptoms post-op, can lead to epithelial breakdown as well. On the OCT, you can make out this spheroidal degeneration, that it tends to block out some of the OCT, and that is probably one of the ways in which you can diagnose that this patient has spheroidal degeneration. This is a patient that we saw quite recently, again, a patient with PBK long-standing, and because of the PBK, he also had a spastic entropion, and because of the lid, a constant abrading the inferior cornea, he also developed BSK over several years. And again, a short sign to diagnose BSK is to do an OCT, because the calcium will completely filter out the OCT, as you can see in the lower OCT here. So you can combine doing the surgery along with doing BSK removal using EDTA, either sodium or potassium, and you'll see that this is the DSEC surgery that we did recently, and you see that the BSK has cleared out completely. Sometimes you also have patients with PBK who have pigmentation on the desmase membrane, and this is an indication of loss or denuded areas of the desmase membrane. So in these cases, it probably is not a good idea to stain with trypan blue during surgery, because the stroma tends to get stained as well, and you will have a slightly more difficult time visualizing the anterior chamber. Other surprises that you might get is, this is a patient who had cataract surgery more than 2 years ago. He came to us with PBK that started about 6 months before he came to us. And we looked at him a little more carefully. If you look at the inferior angle, this patient actually has a nuclear fragment that is left behind in the angle, and the nuclear fragment over time can actually cause endothelial decompensation. That's the fragment on OCT. Sometimes this is the surgery and how the nuclear fragment actually was visible during surgery. So you can see that this can be a significant cause of corneal edema over time as well. Sometimes the nuclear fragment might be present in the anterior chamber, but the cornea might be relatively clear with early edema. This patient had a decent specular count. So we elected to wait for a little while, but then the patient was lost to follow up. And when he came several months later, the edema had become so much more significant. And the other side effect of leaving a nuclear fragment in the inferior angle is the development of synechia, as you can see here, because of the inflammation. And this again will need to be handled at the time of surgery as well. I'd like to end with one case. This is not exactly PBK, but this is actually caused by one of those infernal iris implants. We've seen several of these patients, and these are devices that uniformly and universally should be banned. This is the patient's sibling who had the same kind of implant inside the eye. You can see a lot of inflammation around the limbus, and this patient also has developed uveitis as well as early corneal decompensation and will require surgery pretty soon. This patient that I showed you earlier also had LASIK and had interface fluid in the LASIK flap, but then they can be managed quite easily. Just to show you the side effects of having implants in the eye, not just the IOL, but all of the implants also don't seem to do a good job inside the eye. This is her post-op 3 months, and she did pretty well. So just to summarize, remember that the longer the edema is present in the eye after PBK, it usually takes longer to clear and can lead to structural changes as well. Always look for the position of the IOL, vitreous and nuclear fragments, because these might be X factors that change your surgical approach. Expect a retrocorneal membrane in eyes that are post-inflammatory. Also look for CME in these cases because you might need to handle that. On subepithelial fibrosis, always look for it on an OCT because you can get rid of it at the time of surgery, and most of these cases have very good visual outcomes. Also note previous incisions so that you don't overlap your graft with your previous incisions and you create new incision sites when you're doing your surgery. And if you have some residual scarring on the anterior or the posterior surface, this usually improves over time and does not affect vision quite significantly unless it is very dense and causing a change to the corneal contour. Thank you very much.